going back to looking at like what kind of patient am I doing? Where is she? I really tried to differentiate between what's going to shift in the staffing. How am I going to change? And there are certain things that are going to trump everything else. So if I have a patient who my first clicks are on, she's a triage patient, routine evaluation, she's 1 to 3, but and that's the only thing. That's the only thing I would click for Grace. I would only click. That's it. She's not in labor. I haven't evaluated her yet. She's, there is a time frame in that labor evaluation. A1 standards expect us to see that patient and to evaluate her within 20 minutes. So we don't try not to leave our patient sitting in the waiting room. We try not to delay assessment of the patient, because we've seen negative outcomes when patients wait long periods of time for assessment. So there is a period of time where a routine labor evaluation in triage is 1-to-1. But as long as it's a healthy mom, it's usually such a short window. It's 20 to 30 minutes. So I can get her on the monitor, look at the baby, make sure I have good variability, and that she's truly contracting, get a gist of where she's at. And then she switches over to a normal triage patient of 1 to 3. So if I were using Grace, I would pop in here, I would put my patient in triage room 4, and I would say she's a routine labor, so she's 1 to 3. I'm probably not going to do that. I'm not going to rate the patient until after I've already done the 1-to-1. That was my logic as I was working it yesterday. As a nurse at the bedside, I'm going to take care of my patient. And then when I sit down to call the doctor and give the doctor my findings, that's probably when I'm going to pop into Grace and plug all this in. So for my triage patient, the only thing I need to do is routine. Now, if you fast forward over here to risk factors, right? So my 1 to 3 patient, but I find out she's a TOLAC, which is a trial of labor after a cesarean. I find out she's a TOLAC and I click that, she's automatically 1-on-1, no matter where she's at in her labor progress. She doesn't even have to be admitted. I can still be just evaluating her in triage. I could eventually rule out labor and send her home. So as soon as I click that my patient, so as a nurse, I'm going to go in and assess my triage patient, click that she's a triage, and potentially add risk factors if she has any, and complications of treatments. In other words, I may automatically know that she's a TOLAC and she's going to become 1-on-1 autodynamic. Again, I may go in and say, I'm ruling out labor on a multiple gestation patient. In triage, she automatically becomes 1-on-1. And in labor, she becomes 1-on-1. At delivery, based on the number of multiples, she changes. Like if it's twins, it's 3 nurses for delivery. And because there's a nurse for the mom and a nurse for each baby. Same thing if it's triplets, which happens in level 3 and level 4 facilities, and in any rural setting that they show up in, right? That's the beauty of a rural setting. You have no control over what rolls through your door, and you got to deal with it. That's the beauty of labor and delivery. You could possibly need 4 nurses. So the sublogic to multiples would have to be twins, triplets, more. Because the more babies you have, the more nursing staff you need. I had the privilege of working with, there was a family, they ended up doing a show on the History Channel. I think it was on one of the Discovery Channel maybe. But they were a natural set of quintuplets. That's 5, right? Quintuplets. 5 babies, 4 boys, 1 little beautiful baby girl.
Natural, wow.
Yes. And I'm going to tell you, we had 70 people in the OR. We had ORs, we had an OR, we had a space for every baby, a team of 5 for every baby, a team of 8 just at the table with mom surgically.
Wow.
I've had
So how did you do that? How did that happen? Like, did you call
Planet? And to add to that, not only that was nursing, that was healthcare providers and staff and respiratory and surgeons and blah blah blah, NICU nurses and NICU doctors and pediatricians and all that. But we also, because they were filming for the Discovery Channel, we had a whole film crew in the ORs. A whole film crew. It was insane. It was a lot of fun. I was going to say that it was a lot of fun. Wow. And the babies were beautiful. All 5 were discharged eventually to home. One of them sadly passed away just before their first birthday. They found out that he did not have a spleen, and he was not born with a spleen, and he got I can't remember, upper respiratory infection, I think, and the spleen produces white blood cells, and helps fight infection. And he couldn't fight the infection. He got sepsis and died just shortly before his first birthday. But all 5 babies spent time in the NICU, and then we're all discharged to home. So it was cool. It was awesome. But even in triage, once I click that risk factor of multiple gestation, she's automatically 1-on-1. She automatically trumps everything else. She could be the most stable, healthy, wonderful, incredible pregnancy, and I end up with this beautiful all natural delivery of twin babies that are healthy and 7 pounds, but she for sure. Same thing here, like this newborn modifier, newborn surgery or circumcision, never going to happen in labor and delivery in an LDR. Never going to do never say never, right? Never going to do a circumcision in the labor room, right? Now, in an LDRP or an LDRPAP, where it's one unit houses every patient, absolutely gonna absolutely do that. So I don't want to get rid of modifiers. I want to make sure that I'm unbiased so that we don't create a product that favors a traditional separated unit, because there are more rural combined LDRP NNs than there are LDRs with multiple separate units in separate parts of the hospital. An LDRP and have 2 separate buckets that they can click into. So an LDR is going to get rid of some of this stuff. Like, again, I've never in 35 years done a circumcision in labor and delivery. If I'm going to do a circumcision, the only time I've ever but we do circumcisions in the newborn nursery and we do circumcisions in the NICU. And I can honestly say I have done one circumcision in, I guess that matters. I have done one circumcision, and it's a very sad case, in a labor room. And we had a Orthodox Jewish patient who was in her 40s and unexpected pregnancy. She had a 19-year-old, a 17-year-old, and a 10-year-old, and then this pregnancy. And I'm sad to say the baby died in stage 2 pushing. And he was a beautiful baby boy. And I shouldn't say he did well. He went into crisis while we were pushing. We delivered a baby that had to be fully resuscitated, and the baby went to the NICU for assessment and was later determined that afternoon that there was no brain activity. We resuscitated him for 30 more minutes, and were able to get, just as the doctor was getting ready to call the time of death for the baby, he took a gasp. He took a breath and had a heartbeat. Wow. And we had him intubated, and then he went to NICU. So then, of course, they had to do the full-blown EKG and all that kind of stuff to make sure that there was nothing there. And that family decided ultimately to call in a rabbi from Richmond. I was in Virginia at the time. Call in a rabbi from Richmond who performed the circumcision procedure for burial preparation at the mother's bedside. She couldn't hold the baby or see the baby until the rabbi showed up, because it was after baby was born at 5:00 in the afternoon. So by the time the baby was pronounced, it was after 6 p.m., which is after sunset, and she's not allowed to touch. It was one of the most heart-wrenching deliveries I've ever had. I was charge nurse that day, and I wasn't the nurse caring for her, but I sat with her baby when they extubated him, because she couldn't touch him and she couldn't be with him. She couldn't be in the same room with him. So I asked her permission to stand in the gap for her, and made sure he had 1,000 kisses and some lullabies and before he left this earth. And then I went to the mother's room and we cried a lot. So I think, and maybe I'm overthinking it. Maybe just all of them in here for any type of hospital, they still probably need to pick up whether they're an LDRP or an LDRP, an LDR with separate units, or an LDRP, because it's going to matter what this looks like. Like, what I would like to see here for an LDRP would be our unit map needs to include the moms and the ORs and the triage rooms, right? Now, my unit at a small hospital in rural Texas, we had separate triage rooms. We never used them. We triaged our patients right in our labor and delivery rooms. And we fit the category of any kind of patient, anywhere, anytime, any place, any bed. And you would only see this right here. Some units don't have triage beds at all. Some units don't have an OR at all. And the reason they don't have an OR is because they use the main hospital's OR, which doesn't change anything about staffing. I still need a nurse for the mom and a nurse for the baby. And so all I would do is put a patient in a labor bed and mark she's there for section. And, and she'll leave the unit, go to the main OR, come back with baby. And it won't change anything about what we're doing. except what the capability of understanding what this means to me is assigning a weighted value of care to the patient. Like the patient's going to be level 1, level this one right here. And we talked about this.
Yeah, this is the one from your research, the WEDOC.
But patient, not the nurse.
Not the nursing level, basically.
Well, if this went away, like in my world when I wrote redocs, the expertise of the nurse wasn't a factor. It needs to be. So based on the new perinatal guidelines, this was an ad. It was an ad. So this factor of nurse skill set ties into staffing, but it doesn't change the acuity of the patient. It may warrant me as a charge nurse to change the nurse caring for the patient. To me, level 1, level 2, level 3 was how sick is my patient? Are they a level 1 patient, a level 2 patient, or level 3 patient?
Right.
Not the expertise of the nurse. So in the WeDocs world, the expertise of the nurse and the experience of the nurse was not all of these things down here that we click are what determined whether the patient was a level 1, level 2, or level 3, right? Like, am I a complex patient? Am I a one-on-one patient, a 1 to 3 patient, or 1 to 2?